Greetings, Rep. Lewis, and anybody else just joining us. We're just waiting a couple more minutes, hopefully to get a full commission today. Or at least a quorum.
A quorum would be nice. We do actually have some restorative justice award grants to do. Yeah.
Okay, Vice Chair Bovett, I think this is going to be your show today, or at least what maybe we can do is maybe not change the agenda as initially thought. Start with the research update, and then hopefully we will send messages to the other commissioners in hopes of their attendance for sake of action items. I did want to check in. I know we had asked Commissioner Beach to hang on through action items. I hope that'll still be okay.
Well, let's just see how it goes here and see who shows up. And then I don't have any problem moving to item 3 at any time we think we have a quorum and finish the previous item. So, well, let's get started. For the record, this is Wednesday, August 17th, 2022, 1 o'clock, a regular meeting of the Oregon Criminal Justice Commission. I'm Vice Chair Rob Bovett. Why don't we go around, take the roll on which commissioners are here, and then we'll proceed down our agenda.
Good. Commissioner Auxier?
He's coming right now.
Perfect.
Commissioner Auxier is here.
Excellent. I'll take that as a present. Commissioner Beach?
Present, and just for the record, I'm happy to stay as long as I need for a quorum.
Excellent, thank you. Commissioner Camphy? Vice Chair Bovett?
Here.
Chair Brooks? Okay. Rep. Lewis?
I'm here.
Excellent, thank you, sir, and welcome to the commission. And Senator Brzezinski? Okay, so we do not yet have a quorum.
Yeah, so we need one more for a quorum, right?
Correct.
All right, so let's just keep an eye out for any of our other fellow commissioners that show up. And let's start on the top of the agenda. And then Ryan, if you see anything, just alert me and we can shift around as need be. So let's first start with public comment. Is there anyone from the public that would like to talk with the Oregon Criminal Justice Commission about any matter within our purview that's not on the agenda? Now would be the time to talk with us. Is there anybody out there? If you'd raise your hand, that'd be great. And not seeing any. All right, let's move on to item 2. Looks like we have 10 minutes allocated for a research update from Kelly.
Thank you, Vice Chair Bovett. Good afternoon, commissioners. It's good to see you all. I have a fairly brief research update for you all. You do have a fairly packed agenda, and so leave plenty of time for the business there. once we get one more person in the meeting. So I'll start with the pretrial work. This has been, of course, ongoing for several years now. For those of you that were around back when this started, it's been 3 years, I think. Oregon was one of a handful of states picked to participate in the National Criminal Justice Reform Project, specifically around the pretrial work. And so we've done this for several years. This helped to fund, at least in part, several of our research projects, a lot of which were done in partnership with folks at PSU, and provided kind of that technical assistance. And then some of that research also helped to inform the changes in SB 48 that passed in the last long session. So the last project that is now finished of that big effort was the county pretrial validation work in 9 Oregon counties. And so I think I brought this up last time. It was ongoing, and it has been wrapped up now. Chris Campbell took the lead on that, but then there were also several other folks with PSU that helped in that effort as well. So that one is done, and then that actually wraps up that entire effort with that as well. And so that was a big milestone to reach for us in the research world. Of course, on the policy side, SB 48 already passed, and those things are already happening now. But it's nice to kind of wrap up, this pretty big multi-year effort, and also to help fund the work that was done in partnership with PSU was a pretty big help in that regards as well. Been several pretty rigorous studies that have been made possible by that work. So just want to give you an update on that. Next up is our bias crimes reporting and research. I brought this up last time as well, but it's been a couple months. That report was released July 1, and it is a quite rigorous report on all the different bias crime and bias incident data sources that we have for the state. There were several, there have been a couple of news articles and media reports that have quoted different parts of that report. It seems like the ones that get the most attention is the data analysis on the bias hotline reports. And so those are folks that can call into the hotline to report that something has happened, both to report it and then to engage in services if they choose to. It's a victim-focused service. So the number of reports to the hotline did increase in 2021 compared to 2020. Now the hotline was new in 2020. It was created by legislation in 2019. And so it could be that some of that increase is because folks are more aware of the hotline. There are more referrals going from law enforcement or other community groups. And so we see this increase as there's more awareness around it, which could be a good thing. But then, the other side of that, there's more of this is happening in the community, hence more is being reported to the hotline. And that, of course, is really concerning. And so there've been some of those reports in the media outlets. We did see the largest increase in reports to the hotline for anti-Asian incidents in 2021 compared to 2020. And we continue to see the largest volume of incidents are anti-Black incidents. And so we have a pretty rigorous analysis of the hotline data and other criminal justice data sources of bias crimes and incidents in that report. And then the full report and the executive summaries on our website as well. So wanted to let you know that was out and finished up. And then my last project, my last update is for the STOP program, Statistical Transparency of Policing. So our big traffic stop data analysis work. The law enforcement agencies have reported the data to us through the end of June. And so we are starting that analysis. It's a pretty big lift. It's a really big project. And so we'll have a full report, an updated dashboard, and agency summary pages all ready to go. And that will be due towards the end of the fall. So we'll be working pretty hard on the next round of the traffic stop analysis reporting. Oh, I just thought of this. We've have been in conversation with some folks at the University of Las Vegas that are looking to do something similar. And actually some legislation recently passed somewhat modeled off of Oregon's legislation. So it's been great to connect up with some other researchers and let them know what we've learned along the way as they take on this work for Nevada as well. So just an update there. And I'll stop there and I'd be happy to take any questions.
Great, thank you, Kelly. Any questions for Kelly or comments? Not seeing any. Let's do a real quick check. I suppose we still don't have a quorum, right? If so, we will skip ahead to Jail Healthcare Standards Committee update, if that makes sense to folks. So it looks like Bridget's up.
Hi, Vice Chair Babette. I am just getting the PowerPoint uploaded. So 1 second, it should be right here.
No problem. Well, let's take this opportunity to welcome Chief Lewis or Representative Lewis here as a formal CJC member. It's great to have you, Representative. We've had pretty good attendance in the past from folks on the House side and then on the Senate side too. So it's just incredibly valuable to have you here and be able to essentially feedback stuff to your colleagues of what we're working on. And I just appreciate you being here.
Well, thank you, Mr. Vice Chair. It's an honor to be here. Thank you.
Oh, there's Bridget.
Well, as the PowerPoint loads, good afternoon, Vice Chair Babette, members of the commission. You should see a PowerPoint momentarily about this jail healthcare standards project we've been working on for about a year now. Does anyone see it yet? It says it's loading.
It flashed and then it said, and then it flashed away. So you may have to push this reload button. I guess I can do it. I'm reloading it. Oh, that didn't change anything. Uh-oh. We see flashes of it. That's what's so, huh.
I am working on it. This usually isn't the hard part. Okay.
Yeah, I probably should go on mute because I'm AV incompetent. So I'll let the smart people do that.
What I'm going to do, just to save us time, is to, rather than try to upload it into Teams, I'm just going to share my screen with the PowerPoint on it. We might lose the recording of the actual PowerPoint, but we'll make sure we include it in any materials that folks need, so they'll get copies of it. But I don't want to waste time on a tech glitch because no one has time for that. So we're going to do this the old-fashioned way.
And don't worry about time pressure because we don't have a quorum. So unless we get a quorum, you are the last item.
Okay, can folks see this now? Perfect. Okay. Oh, wait a minute. I'm sorry. Can you see my whole screen with my notes and everything too? Okay. No, just the PowerPoint. Okay.
I just see the slide, Bridget.
Okay, thank you. All right, we'll get going. Again, Vice Chair Babette, members of the commission, thanks for letting me present today. This is an update on the Jail Healthcare Standards Advisory Council. This is a group that has been meeting after House Bill in 2021, 3229, convened this group to look at minimum jail healthcare standards, the development of some sort of independent jail commission, and other sort of best practices in consultation with the commission. And we have a report due to the legislature in about 1 month. Just because I think this is sort of good to note, this is our member roster, just as a reminder for folks who are familiar with it and for anyone who's new. I'd also like to just say thanks to this group. We're not done yet, but it has been a really, really engaged group. And anyone who's staffed this kind of thing before knows that that makes all the difference. One other thing I wanted to note is the bill itself did not appoint anyone with lived experience, receiving healthcare in a jail or being a family member or an advocate for someone who's receiving healthcare in a jail. And we have had a couple of folks sort of unofficially part of the work group who have that experience, and their experiences and comments have been invaluable in sort of identifying perspectives and experiences that other folks just don't have. So again, thanks to this group, they really made a lot happen in a pretty short period of time. So real quick, just a little bit of overview. We won't spend too much time on this, but this project is specific to local correctional facilities, which are the Oregon municipal and county jails, as opposed to lockups or short-term holds. So these are places where folks are held 36 hours or longer. And in Oregon, we have 39 of these, 31 of which are county jails, 8 are municipal. And this is a draft map. The report map will be fine-tuned a little bit more, but this is just to show folks like where are they in the state. There's a couple of places where jails are co-managed or folks, I guess, contract for bed space. So in other words, not every county runs its own jail. And another thing that sort of came up a lot and frequently with this project was, oh, well, if you're trying to make recommendations for minimum jail healthcare standards, there must not be any in existence. And that's not the case. We have some statutory standards at ORS 169076. They are quite broad. They're not terribly specific, which for statutes is probably a good thing because standards change, practices change, and you probably don't want too much detail that gets stale fast. There's also voluntary standards promulgated by the Oregon State Sheriff's Association, which they are non-binding. Folks don't have to adopt them, but they are widely followed and they are quite detailed. Even there, we have found some gaps in places that, topics that haven't been fully addressed there as well. And last but not least, just as a reminder, jails are also subject to other state laws and some federal laws like the Americans with Disabilities Act. So that is all to say in concert, there are lots of things that regulate jails. So we did not invent this with this project. And of course, if anyone's questions at any point, please let me know. Another thing that I think folks might be unfamiliar with is, who provides jail healthcare? There's a lot of different ways it can happen. And in Oregon, we have so this is of jails that responded to a survey we administered, or actually in part administered, and then other information was provided by the Oregon Jail Command Council's annual survey. But about 2/3 of respondents, which amounted to most Oregon jails, have some sort of contracted way of doing this. Either they pay a corporation like NavCare or WellPaths for their staff to provide healthcare in a jail. They might contract with a local provider like a local physician or a nurse. And then about 1/3 of respondents, this is going up slightly, you'll see in 2020, but about 1/3 of jails have in-facility staff. So like I said, there's lots of different ways to do this, and you'll see variations, particularly in very small jails or very rural or frontier jails, where it's really hard to get folks in your facility to provide this care, because it may also be hard to get those folks to provide care in your community as well. So the bill itself had key components that we were tasked with addressing. First was these minimum jail healthcare standards. The second piece was some sort of independent commission design. Next was implementation specifics, costs, suggested funding sources, timelines. And last was anything, promising local practices, national best practices, and other things that the legislature should consider changing. And I will say that third piece about implementation, like figuring out costs, has been a little bit difficult. So we're not quite done with that yet. I mean, we're still working on this whole draft, I should say. So there's still work to be done. It is due in about a month, and we have a couple more meetings to go. But as a review, I'm not going to belabor the specifics that House Bill 3229 laid out, because this, we have talked about this a little bit before. But essentially, it laid out about 7 very specific topics that the legislature is looking for some sort of minimal standard on. Includes things like licensure requirements or qualifications for who provides services in jails, staffing levels, screening needs, scheduling appointments. And really, after about a couple of months of meeting and talking about this stuff, it became clear that trying to figure out a very specific solution that would be workable in all facilities may not be the best approach for a couple of reasons. And I'll get to my next slide because I think this helps it make a little more sense. There are 3 kind of main problems that you'll see influence all of the responses to the policy positions or policy questions asked in 3229. And they can kind of be summed up in like these 3 boxes: lack of Medicaid coverage while folks are incarcerated, continuity of care barriers between institutions like, let's say, a jail in the state hospital or a jail in the community, and just overall healthcare professional shortages, which is true outside of jails and in jails. So that is kind of just a preface I want to give before we start talking about the individual pieces, because the key takeaway seems to be to write just a specific set of new jail standards is probably not going to be as effective as trying to tackle some of these bigger picture issues first. So the way this has been sort of set up is going through each of the 3229 topics with sort of the key, one of those 3 barriers identified, and then some of the solutions or discussion points that have been part of the Jail Healthcare Council so far. So first is just this qualifications and licensure requirements for healthcare folks. The Jail Healthcare Group has really talked about how we have a lot of rigorous standards and licensures and board certifications that already exist. And adding new ones or jail-specific qualifications doesn't really make sense. What does make sense is trying to essentially entice, more folks who are engaged in medical professions to want to work in jails. And how do we do that? So you'll see this come up in a couple of these topics because it is sort of this overarching problem. If there's not enough, there's essentially a shortage for in-community healthcare. And that shortage is more acutely felt in facilities like jails. So what can we do to do, continuing education, training opportunities, student loan forgiveness? One interesting thing is that there's a corrections medical care task force working on sort of the DOC side of this. And some of their draft recommendations also include things on how do we entice new medical professionals or existing medical professionals to want to work in facility with our incarcerated populations. So that's kind of where we came to, at least on this topic so far. The next topic was access by folks in custody to medical folks who can prescribe medications. And you'll see all 3 barriers arise in this setting. There's continuity of care issues when a person is on a prescription when they arrive at jail, but maybe that jail for certain jail protocols like medications that are easily diverted, or maybe it's too expensive, or maybe the jail medical professional like the supervising doctor or nurse doesn't agree that that's the prescription you should be on. There's all these sort of barriers that come up on continuity of care in the prescription realm. And one of the things that we talked a lot about was this regional or statewide medication access program. It's really interesting. There's it's actually the Minnesota Department of Administrative Services, which is essentially the same as Oregon DAS. They administer a program where states or municipalities can contract with them to buy medications that jails need a lot of at government rates, which is going to be better than a rate you would get through a pharmacy that was a private contractor. Jails that have done this have saved a lot of money, and it's just been a more streamlined process. It's not to say that this is an easy goal to achieve, because things like having electronic health records really helps facilitate this. Our Department of Corrections would be sort of the natural hub, and they don't have electronic health records yet. So there are some key barriers there, but in sort of smoothing over this continuity of care issue for medications, that has been discussed as a really good starting point, or at least something worth exploring. The second piece is really, there's been some new guidance from the US DOJ's Office of Civil Rights on the Americans with Disabilities Act regarding medication-assisted treatment in jails. And essentially, the guidance says, if you are on something like an opioid use disorder medication-assisted treatment before you went in jail, the jail can't just say, we don't do that here. That's a violation of the Americans with Disabilities Act. So, for any sort of jails that maybe don't know that, or have trouble with resources associated with providing medication-assisted treatment, the conversation here has been about how this independent jail commission could provide technical assistance, maybe grant writing help, that kind of thing to make sure all of the Oregon jails are on the same page about that compliance. And then last but not least, like I just said, providing resources to jails to seek out medication-assisted treatment if they haven't done it before or if it's been funded sporadically, things like that. And again, if there's any questions, please stop me. I'll just keep going until I hear one though. So staffing levels and round-the-clock on-call healthcare was another one where it became pretty clear pretty fast. You can mandate minimum staffing, but if there's no resources and no professionals to do it, it's going to be meaningless. So what can you do instead of creating something like a hollow mandate and support jails and medical professionals and sort of meeting the needs that are felt? So one idea was we have things like resource prosecutors for sort of specialized case types like elder abuse or animal abuse, because not every county can afford to have that specialized prosecutor on the roster. So what if we had, maybe through OHA, maybe through somewhere else, sort of regional teams that you could deploy to places that are, feeling these resource shortages most acutely. And of course, it couldn't be an overnight thing. It might have to be things that are more routine, like maybe, everybody's annual checkup or something like that. But just to relieve the resource burden from these particularly small, understaffed jails that would probably have more healthcare professionals around if they were available. So that would, it would put more of the burden on the state to sort of create these teams, but there is some feeling that would really alleviate some of the biggest lack. Of course, there's also the conversation, particularly post the very beginning of COVID when telehealth wasn't used as much. Now, a lot of people are really familiar with telehealth, but it's supporting the expansion of telehealth to the greatest extent possible when it's medically appropriate, because it's not always. There are some appointments that you really should just see someone in person. And then, of course, as we mentioned previously, training opportunities, incentivizing jail medical employment with student loan hiring bonuses, those kinds of things that make more people available to do the work. Protocols to ensure timely transfer and continuity of care. This is another one where the solutions are much bigger than, sort of specific, must do this in a number of hours kind of things. One of the chief ones is, folks are probably familiar that when a person becomes incarcerated, they lose any sort of public benefit, like for medical care, like the Oregon Health Plan, Medicaid, within about 24 hours of their lodging. And that's a federal policy through the Social Security Act. It's been around for like 50 years. Individual jails and states can't do anything about that on their own, although the Oregon Health Authority is engaging in their sort of current 1115 waiver. And they've asked to negotiate with the feds on expanding Oregon Health Plan coverage in limited circumstances to people who are in jail to help with screenings, things like enrollment in CCOs and transitions to community providers to really kind of alleviate some of those things that really should be given to everyone. Counties just maybe can't do it all the time. The next piece I think is probably our biggest recommendation, and maybe the most substantial, and that is placing the burden of reinstatement of the Oregon Health Plan back on the state rather than on the individual who is releasing from a jail. And how this works now is if I'm a person who's released from a jail, I have about 10 days to contact OHA and ask them to reinstate my benefits. If I don't do it within that 10-day period, I have to reapply for those benefits. And it's a very complicated process. Some counties have what's called an OHP assister who can do that on behalf of the person releasing, but most jails just don't have that person available. So if we were to place the burden on the state to essentially turn the button back on, a lot of people would be insured immediately upon release rather than hoping, based on all of the other things they've got going on when they've released from jail, that they're going to be able to find OHA's, the right phone number, the right contact person, and make that request. The next recommendation there is supporting expansion, and this is a big one and a complicated one, of these non-jail, non-state hospital settings for folks in the forensic population. So there's not this kind of continuum where, well, you've got two options. You can be in the state hospital being restored, or you can be in a jail decompensating. And we're going to hope that your sort of trial date matches up perfectly with where you are on that time frame. So instead of having sort of those as your two key options, if we had more secure residential and outpatient facilities just around the state, provide that sort of medium-centered, in the middle care, folks wouldn't have to stay at the jail or the state hospital as long. And then last but not least is increasing transition planning between institutions, particularly state hospital and jails, to the greatest extent possible. To the extent you can do it, supporting reentry from jails into the community, but that can be really tough because you don't know when people are getting out a lot of the time. It can be really sudden, and it's just kind of complicated when you're releasing from a jail. But things like peer support, transition centers will help a lot of those things. This is just an example. This is if I were a person trying to reapply for my OHP. If I had missed that 10-day window, I could do a paper application. It's 52 pages long, much of which is not specific to the individual, like a lot of it is if you're adding a family member, but it is immensely complicated. And if you didn't have a paper copy, didn't have a computer, and you're doing this on your phone, I mean, it would be quite the burden. And then there's, on the right there's this online option. And there might just be questions on that first landing page that are really hard for people to answer. If you're brand new out of jail and you're trying to, get your footing under you. So screening healthcare needs of folks in custody. Right now, the Oregon Jail Standards through the Sheriff's Association has 5 mandated screenings. So we have a lot of screenings that are routine in most jails. So the jail healthcare recommendations were, these screenings should be routine. The contents of those screenings would really be better left to an independent jail commission to manage and maintain over time, rather than trying to put something in statute that says, you're going to do these screenings, they're going to say these things at these times. Scheduling appointments and establishing confidential spaces. These are 2 of the House Bill 3229 topics we don't have specific recommendations for at the moment. That's because a lot of this stuff hopefully would be addressed by some of these bigger ticket issues. First things with scheduling and administering appointments. You can schedule an appointment, but if no one's there to provide you the health care, it's not really going to work. So that is sort of one of those big resource shortages that should be addressed further upstream first. And then in confidential spaces, that's a tricky one too, because some of that has to do with jail architecture, and modifying jail spaces is really difficult. But some of the things that have been discussed is, these regional provider teams, telehealth expansion, medical professionals, just having more people available would alleviate. Sometimes jail staff have to do these screenings at booking, and that's done in kind of a big, loud, noisy, chaotic section of the jail. If you had more medical staff to do it, folks might feel more comfortable telling people they know to be doctors or nurses those kinds of things than someone they know they're going to see staffing the jail kind of all over the place. And then last, we also had some input given on the need for gender-specific spaces for medical care. So this is one of those things that really the Independent Jail Commission should work on over time, but putting something in statute might be kind of a hollow mandate at the moment if there aren't resources to really make it happen. So we're going to transition to the second part of this project, which is providing some sort of independent jail commission for healthcare. And before I started that, I wanted to give just a brief update or overview on what jail oversight exists now. There's really 3 levels. There's the state level, local level, and then this sort of voluntary, you decide that you're going to follow standards because it's a good thing to do. First and foremost is the state DOC has an obligation in statute, and then they detail this out in rule on routine inspections. They don't define like what routine is, but if they have a sort of a pattern of inspecting jails based on those statutory standards. DOC must refer any out of compliance jails to the Attorney General's office. Interestingly, DOC and the AG just have never had that happen. So either jails have never been out of compliance, or it's just not a means of compliance that's used at all or very often, because no one had any memory of it happening. At the local level, there's a couple different ways this happens. Jails internally inspect themselves if they are following the OSSA standards. County commissions or county courts, depending on what kind of county you have, must inspect jails at once during the regular term. Local health departments may inspect jails on a semi-annual basis if they see fit. And DA's offices may convene grand juries to, or I should say, must convene grand juries to conduct these annual tours and produce reports. And if anyone wants an example of those, I've got a couple saved just to see kind of how they take shape. At the voluntary level, again, the Oregon State Sheriff's Association has pretty detailed standards that frankly, every jail that I've encountered follows. And they have formal inspections every 2 years, and jails must self-inspect every year in between the formal inspections. Lastly, some jails can strive for national accreditation through things like the National Commission on Correctional Healthcare. To my knowledge, we only have one jail that's been able to do that in the state. It is resource intensive and it costs money to be evaluated, and that is Clackamas County. So here are the things that the House bill laid out for what our jail commission should, what recommendations should follow the Jail Healthcare Commission. Name the commission, who's going to be on it, how long, who appoints them, where should it live in state government, how should it conduct business, and how often should it report to the legislature. So far, the Independent Jail Commission has a couple of names people are tossing around. So far, the group likes the Oregon Jail Healthcare Standards Commission, and then other folks like the same by putting in the resources word, because there is this discussion about scope of duties, and there's a lot of good evidence that suggests that having a commission like this, where your only job is to essentially look for jails out of compliance and nothing else, is no one will succeed. Jails don't get better when you just tell them they're doing something wrong. If there's no resources or technical assistance or guidance provided as to how to meet standard or provide resources if a standard can't be met, like a variance, you're just not very successful. Things won't improve if that's the only method you have. So where should this be housed? So far, folks have sort of reached consensus on an executive branch agency because that would give it rulemaking authority. And the leading vote so far is CJC. Or the DOC's Office of Ombudsman when it is sort of up and running because it is very new. The appointing authority, so far folks sort of agree that it should be governor appointed and Senate confirmed to give, sort of two branches a little bit of balance on who's on this sort of thing. Membership should include reps of Oregon jails, healthcare professionals, and people with lived experience receiving healthcare. That's not to say there should be 3 people, should be, a bigger group, but not too big. We're looking at, allowing for subcommittees so that specific expertise can be organized and particular areas you need it to be. There's also a lot of discussion about a robust self-nomination process because, as folks know, to get appointed to something like this, you kind of have to be a known quantity. And particularly with folks who have lived experience, it can be hard to get your name in the hat. So there's a lot of interest in allowing people to nominate themselves rather than have to be selected by an association. And then the term limits, I put 6 in brackets because this is kind of under discussion. But right now we're looking at 6-year terms, ideally staggered so that everyone doesn't expire at once. This is my last information slide, so we're almost there. Meeting protocols, we didn't detail this out too much because I frankly don't think it's the most important part of this project, but regular public meeting rules, robust means of public participation. So, when you have public comment where folks have to sign up way in advance or they have to put stuff in writing, it can really kind of chill people's comfort with participating. So, aside from the basics that every public meeting has to do, there should be, make this transparent and available to the public. Reporting to the legislature should probably happen on something like an annual basis. Topics should include any standard that was changed, revised, repealed, any issues with compliance, and the technical assistance provided to any jail found out of compliance, as well as anything else the legislature should know about sort of the context jails find themselves in. And lastly, the independent commission should probably be given authority to hire a staff, such as an executive director or some staff person, because somebody's got to write the report. And last, and this has sort of been discussed a little bit, but giving a commission like this just a stick and nothing else is just really going to be ineffective. So there should be kind of a two-way exchange of information. Should be there to help jails, get better. And that's it. So last slide. Next steps: the Jail Healthcare Commission or Council has 2 more meetings to review these drafts. We're working on tiering recommendations in the top priorities because, right now I think there's 13 recommendations. It'd really help the legislature if they could see, these are the really most important 3 things you should do first. We're also still working on those timelines and costs. It's due on the 15th, as I noted. And then once it's turned in, I don't think we're done. We're sort of preparing to do a road show to get more input and then greater detail on how this might all work if it is in fact implemented. So that's all for me. I hope that's informational. And then if anyone has any questions, I'm always happy to help. So.
A great update, Bridget. Thank you so much for that. Anybody have any questions or comments for Bridget? I guess my only one is, do we have a placeholder bill anticipated that we're kind of putting in there that we can stuff with whatever it is that we come up with?
Vice Chair Babette, yes, we have a placeholder LC that essentially says relating to jail healthcare.
Perfect. Perfect. Okay. That was my only question. Anybody else have any questions? No. Well, folks, Ryan, do we have a quorum?
Looked like there was a comment from Commissioner Beach. Real quick.
Oh, yeah. Okay. Go ahead, Commissioner.
Thank you, Vice Chair. My apologies. Real quick, Bridget, going back to your presentation on the House Bill 3223 and that legislative concept that Vice Chair just mentioned, is there any discussion about adding juvenile detention facilities or OYA or youth authority facilities to this type of requirement, Commission?
Commissioner Beach, we have not tackled youth in custody just because the bill is specific to local correctional facilities, which are for adults. I think it's a really great question, but not at this time. And it certainly, I'll keep you posted if I hear anything that might expand the bill to further populations.
Understandable. I know it's a lot of work. Thank you.
Great question. Anyone else? Questions, comments? Back to you, Ryan. Do we have a quorum?
We are not going to be able to make quorum this afternoon.
Okay, so we have restorative justice grant applications and specialty court grant applications. Do we need a special meeting to get those done? Or is there any timing pressure on those, or can we kick those over to the next regular meeting?
We'll have to take a look at that a little more closely and maybe make that call and reach back out to the commission.
Sounds good. Well, is there anything else staff want to have the commission do before I guess I adjourn this meeting, because it doesn't look like we can do any more. And Ryan is shaking his head. So, all right, folks. Well, we'll get out a little early today. 45-minute meeting. Thank you all for being here, and we'll be in touch potentially sooner rather than later about those 2 other grant program awards if we can get a meeting going here real quick. We'll see. Thank you all, and have a great rest of your week. We are adjourned.